Good afternoon, everyone. We're going to get started. Thank you for joining us on this webinar titled Intervening with Cancer Caregivers to Improve Patient Health Outcomes and Optimize Healthcare Utilization. My name is Michelle Malika, and I am joined by Dr. Erin Kent. We are both program directors in the Healthcare Delivery Research Program at the National Cancer Institute. Before we get started with our webinar, we wanted to give you some logistical information. You can submit questions at any time during the presentation by typing into the Q&A feature on WebEx on the right side of your screen and press Submit. In addition, this webinar is being recorded. And in our webinar today, over the next hour, we will present some background on funding mechanisms, specifics regarding this funding opportunity announcement, and then we will take your questions regarding this FOA. First, we thought we would give you a background about where we are situated within the NCI. The Healthcare Delivery Research Program is part of the Division of Cancer Control and Population Sciences and is one of 4 research programs within the division. Other research programs include the Behavioral Research Program, the Epidemiology and Genomics Research Program, and the Surveillance Research Program. The program's main mission is to advance innovative research to improve the delivery of cancer-related care. We have 3 branches, including the Healthcare Assessment Research Branch, which assesses utilization, access, diffusion, and population-based outcomes, the Health Systems and Interventions Research Branch, which supports research to observe and intervene on behavior and context, and the Outcomes Research Branch, where Erin and I are located, which supports research to evaluate and improve patient experiences and health outcomes. Although most of our grant portfolio consists of investigator-initiated grants, the Healthcare Delivery Research Program also supports grant applications in specific areas of interest through the following mechanisms. Requests for applications identify specific receipt dates, the estimated amount of funds that are earmarked for the initiative, as well as the number of awards likely to be funded and other specific review criteria. Program announcements, which are submitted with a standing receipt date and reviewed along with other applications using the standard peer review processes. And program announcements with special receipt, referral, and other review considerations. Applications in response to the Caregiving Funding Opportunity Announcement that we will be discussing today will be in one of 2 grant mechanisms, the R01 and the R21 mechanisms. Most of you may be familiar with these mechanisms, but just to review, the R01, which is one of the most common mechanisms, supports a discrete, specified, and circumscribed research project. There is no specific dollar limit in the R01. However, advance permission is required for direct costs over $500,000 in any year. And R01 grant mechanisms support 3 to 5 years of funding. R21 mechanisms support new exploratory and developmental research projects, are sometimes used for pilot and feasibility studies, and usually may not exceed a budget of $275,000 for up to 2 years of funding. At this time, I will turn things over to Dr. Erin Kent, who will introduce the topic of informal cancer caregiving.
Thank you, Michelle. I would like to start by giving some background on informal caregiving, caregivers, and specifically caregiving in the cancer context. When we use the term informal, and sometimes we use the term family caregivers, we mean individuals that assist family members or friends by providing care which is typically uncompensated, usually in the home setting, and care that involves significant efforts for extended periods of time. Being a caregiver is really characterized by the tasks that the caregivers take on, which can be many and varied. These can include monitoring for side effects, managing symptom burden, helping care recipients make treatment decisions, coordinating care among healthcare providers, triage or making decisions about whether an emergent health problem requires immediate medical attention, administering medication, an increasingly complicated task given the many new agents and multimodal regimens that care recipients may be on, and managing a care recipient's financial and social obligations in concert with a caregiver's own. Caregiving in the context of cancer presents a unique aspects worthy of mentioning here. The nature of cancer, in contrast to other chronic illnesses like dementia or Alzheimer's, can lead to rapid deterioration in a person's health over a short period of time and cause heightened distress in family caregivers. Cancer caregivers typically spend more hours per day providing care, provide more intense care over a shorter period of time, and are often more likely to incur out-of-pocket expenses than do caregivers of individuals with other chronic illnesses. And care is increasingly being moved to the outpatient rather than inpatient setting. Cancer patients can experience more variability in symptoms and toxicities from different multimodal therapies than do individuals with other chronic illnesses. This can necessitate their caregivers monitor their health status frequently and use a variety of technical and psychosocial skills to promote patient health. The unique inflection points specific to the cancer care continuum, so that is diagnosis, treatment, transitioning off treatment, survivorship, and end of life, also can lead to variability in the level of care burden and ongoing adjustment unique for cancer caregivers. Finally, a unique hallmark of cancer is the possibility of recurrence, stress for patients and caregivers alike. So, not surprisingly, many cancer caregivers report cancer-specific stress that can have a measurable impact on caregiver health and well-being. In addition to the stress on caregivers themselves, cancer patients report concern about how cancer may have a negative impact on their families. As shown here, results from a cancer patient survey led by Cancer Care in 2015 found that together, 76% of patients ages 25 to 54 and 48% of patients ages 55 and over reported being somewhat to extremely distressed about the impact of cancer on their families. Furthermore, efforts to determine how many caregivers are caring for cancer patients in the U.S. are ongoing, but challenging due to the lack of national data sources or registries on caregiving. The National Alliance for Caregiving, in partnership with the National Cancer Institute and Cancer Support Community, published a report called Cancer Caregiving in the U.S. based on data from the 2015 Caregiving in the U.S. study. The study was based on an online probability sample of caregivers across the U.S. Cancer Caregiving in the U.S. compared those who reported caring for individuals with cancer to those who cared for individuals with other health problems. Findings included that approximately 2.8 million adults were currently serving as a caregiver to another adult with cancer, caring on average about 32.9 hours per week. In addition, 43% of cancer caregivers reported performing complex medical or nursing tasks without any prior preparation. 50% reported high emotional stress, which was significantly more than non-cancer caregivers, and 25% reported high levels of financial strain. These results underscore the impact of the cancer experience on caregivers and the need for interventions that address their unmet needs. In May of 2015, along with colleagues from both the NCI and National Institute of Nursing Research, we led a two-day meeting with over 75 attendees to discuss the state of the science, research, and clinical priorities for informal cancer caregiving. We published the results of that meeting in the journal Cancer last year, and I'll briefly go over some of the summary recommendation areas. The key areas of focus and resulting recommendations that were covered in the meeting and subsequent paper are as follows: expanding the assessment of prevalence and burden of cancer caregiving, improving interventions for cancer caregivers and patients, maximizing the positive impact of technology in the realm of cancer caregiving, and facilitating further integration of caregivers into the healthcare system. Now I'm going to focus on one area which led to the development of this funding initiative, improving interventions for caregivers and patients. The meeting and subsequent paper discussed the need to prioritize health outcomes of interest, improve definitions of constructs on caregiving, and begin an effort to harmonize measures across studies. Examine the effects of interventions on patient and caregiver outcomes, healthcare utilization, and cost effectiveness. Increase the inclusion of diverse populations and those underrepresented in research, and replicate interventions that show some benefit and attend to fidelity and dose considerations. With that, we released the following Funding Opportunity Announcement, or FOA, intervening with cancer caregivers to improve patient and caregiver health outcomes and optimize healthcare utilization, which has announcements at the R21 and R01 levels to fund interventions that support the success of informal cancer caregivers for adult cancer patients as measured by the following outcomes: improved patient health, for example, physical health, symptom burden, health-related quality of life and functioning, improved caregiver well-being, and optimized healthcare utilization. So, for example, patient readmission to the hospital, emergency room visits, caregiver use of healthcare services, and caregiver use of cancer support services. And now I'll walk through the details of the Funding Opportunity Announcement. Applications submitted to this Funding Opportunity Announcement must have study designs that consist of a behavioral or healthcare delivery intervention with random assignment in a control group. R21s, however, need not consist of a double-arm RCT. Applications submitted as R21s can propose to develop and test acceptability and feasibility of an intervention planned for further larger-scale testing and development. Interventions must be delivered at least to the caregiver, although they can also be delivered to the patient or care recipient as appropriate for the particular study. Patients must be at point of diagnosis or forward on the cancer control continuum. Studies conducted with patients in active treatment, transitioning into survivorship, with advanced cancer or at end of life are acceptable. Only studies conducted with patients ages 21 and over at diagnosis are eligible. The outcomes targeted by the interventions must include all of the following: at least one cancer patient level outcome, whether it be behavioral, physical, and/or psychosocial morbidity, at least one caregiver level outcome, again, behavioral, psychosocial, and/or physical, and at least one healthcare utilization or health system level outcome related to care delivery, program implementation, and/or sustainability. In addition, adjunct mixed methods and/or qualitative studies to determine the most effective components of the intervention are encouraged in the context of the above study designs. Development and testing of assessment instruments to evaluate cancer caregiving are also encouraged. And furthermore, special consideration will be given to applications that target underrepresented or medically underserved populations. In the research strategy section of the application, applicants should describe the proposed project using the standard subsections, significance, innovation, and approach. The description must address all of the specific aspects listed below: a clear definition of the target cancer patient and caregiver population, as well as an indication of how the project addresses persistent and salient problems for the specified population, the inclusion of a research team with appropriate caregiving science and health services expertise, a description of how the intervention will balance improvements targeted in all three outcome areas identified by the FOA, so healthcare utilization, caregiver well-being, and patient health, and a strategy for how the intervention, if successful, will be appropriately disseminated. There are some specific review criteria in addition to the standard review criteria for R1s and R21s under the following section. So under significance, does the project address persistent and salient challenges that the targeted cancer patient caregiver population faces? How amenable is the proposed intervention for dissemination and implementation? Under investigator, does the research team include appropriate caregiving and health services expertise broadly construed? An approach, does the intervention appropriately balance improvements targeted in all three outcome areas: healthcare utilization, caregiver well-being, and patient health? As it stands now, here are the remaining receipt dates for the FOA. October 10th, 2017, April 11th, 2018, October 10th, 2018, and April 11th, 2019. So note that these are special receipt dates for applications. There are only 2 submission dates per year, and this includes resubmissions, or A1s. Letters of intent are not required, but encouraged as they help both program and review plan to review for the applications, and we ask that they be sent via email to the program officer listed on the study FOA about 1 month prior. And we encourage everyone to start the process early, which will allow time for registration and System for Award Management, ERA Commons, and Grants.gov. Today's webinar and the questions that are posed will be posted on our website in a few days or weeks' time. We'll let everyone know. And we encourage you to reach out with your program directors early. And please continue to check for the funding opportunity announcement for any updates, announcements, and of course, contact information. Wanted to point out some additional resources. We encourage you to look up our Cancer Caregiving webpage on the Healthcare Delivery Research page, and the URL is listed right there. We have links to the PAR that we're presenting on today, as well as other funding opportunity announcements relevant for cancer caregiving. We also have links to reports and resources for research on cancer caregiving, including what you see here on the far right of the slide, the recent study conducted by the National Academies of Medicine entitled Families Caring for an Aging America. Among its key findings were recommendations were for a strengthening of the research infrastructure to support more research to understand the needs of caregivers and how to develop better interventions to improve both caregiver and care recipient health outcomes. And finally, some of you may have attended in person or virtually the National Institute of Nursing Research-led meeting on August 7th and 8th, The Science of Caregiving, Bringing Voices Together, which updated the community on the state of the science of caregiving, including a session on caregiving for patients with acute and serious life-limiting disease. And this panel had research presentations on cancer caregiving specifically. For anyone who might have missed this meeting, I encourage you to look at the videocast archives on nih.gov, and you can just use the name of the meeting and search for it that way. So in summary, today we presented on intervening with cancer caregivers to improve patient and caregiver health outcomes and optimize healthcare utilization, a funding opportunity at the R01 and R21 level. This announcement is designed to fund interventions that support the success of informal cancer caregivers for adult cancer patients as measured by the following outcomes: improved patient health, improved caregiver well-being, and optimized healthcare utilization. We encourage you to read the online announcements carefully, contact us with any questions and the specific aims of projects you might be considering, and we really hope that you'll apply to this funding opportunity announcement. Just wanted to put our contact information up on the slide in case anyone missed it. Although, as we stated before, the recording of this webinar will be made available shortly on our website. With that, I'll hand it back over to Michelle.
Thanks very much, Erin. So at this time, we would be happy to take your questions. So please feel free to type your questions into the Q&A section on WebEx. It's at the bottom right-hand part of the WebEx screen. We do have a couple of questions coming in. The first is, are these applications being reviewed by a special emphasis panel? And Erin, I guess I'll take this first question. So the answer is yes. This review falls under the purview of the Center for Scientific Review at NIH. And their goal really is to convene a panel with all the relevant expertise necessary to review these applications. The program directors do their best job to advise the Center for Scientific Review on the types of disciplines to include on the panel. And because this announcement focuses on informal cancer caregiving interventions, the panel will likely have expertise in nursing science, behavioral interventions, health services research, palliative care, psychosocial oncology. Investigators can help the Center for Scientific Review and the program directors by submitting letters of intent and by writing cover letters that specify expertise that you think is necessary to evaluate your proposal. A next question, Erin, is how are you defining balancing the three outcomes of caregiver well-being, patient health, and healthcare utilization, and can one be primary over the others?
Sure, yes, absolutely one can be primary, and I think in most cases patient and or caregiver health is going to be considered primary. It really depends on the research question, the aims, and the sort of place along the cancer care continuum, I think. I think this is the kind of thing that it's best to reach out to a program director to help, you know, as you're developing specific aims, to help try to figure out what makes sense to prioritize.
Okay. And Erin, can you talk about some of the sort of pitfalls or issues you've seen in peer review with this mechanism, specifically regarding the measurement or impact of healthcare utilization outcomes, and specifically in the context of R21 applications?
Sure. That's a really tough one. Yeah, I think that we certainly recognize that we're asking investigators to do a lot, but we truly feel that because there is a lot of, I think, interest in and some effective interventions that have been developed to help support caregivers. They're not being readily implemented, and so we really felt strongly about demonstrating the impact, if there is any, of these interventions on measures of healthcare utilization. Now, this is where having health services research, you know, somebody who is either a true card-carrying health services researcher, great, or someone who has experience conducting health services research and health service interventions specifically is of benefit. I think it's hard to talk very broadly about common pitfalls, other than I would say, you know, one of the things that's common to, I think, pitfalls of R21s across a variety of announcements is trying to find that sweet spot between really truly moving some science forward, but not being overly ambitious. If I would suggest in general, and this is always going to be, you know, talk for specifics, you need to talk to a program director one-on-one, but in general, I would tell people not to shy away too much from the R1 if you have preliminary data. I think there's a tendency to want to start at the R21 most of the time, but it's a harder bar actually to get funding typically with R21s, and so, you know, I would really think critically, think ambitiously even about applying for an R1 if there is preliminary data and the intervention seems to be ready to test at that level. So anything further, I would say, please reach out to one of us, and if we're not the most appropriate scientific contact, we can direct you further for questions about your specific ideas.
Thank you, Erin. So another question is, are new applicants who have not had prior NIH funding before encouraged to apply? I would say the answer is yes. We welcome applications from new and early stage investigators. If you are new to the NIH application process, we strongly encourage you to consider working with someone who has experience in the NIH grants process, possibly a colleague or expert at your institution, and we also encourage you to reach out and make contact with the scientific contact on this FOA. Erin, another question is, you mentioned that R21 applications don't necessarily need to involve a control group. Do you happen to know if applications that do have control groups are reviewed more favorably than those that do not?
That's a really good question. So, I mean, I don't think we have sort of a pool of applications large enough to really be able to comment definitively on that. But, you know, the messaging here should go out to both prospective applicants and also reviewers that in an R21 setting, one shouldn't have to test a full-blown 2-arm RCT. That said, depending on what the type of intervention is, if it's something that is that has a, it's a less intense intervention, it may be something that is within the scope and budget of an R21. I think it's too difficult to say that a single arm that's designed to test acceptability and feasibility is always going to score more poorly than a double arm RCT. I think it really is going to be related. The approach here is going to be related highly to the significance of and potential impact of the intervention within the specified population. So this is definitely a question to talk to a program director one-on-one about for any given study and any given investigator.
Okay, and in considering measures or operational definitions of healthcare utilization, do you have thoughts, Erin, on appropriate measures or definitions in terms of ER visits, hospitalizations, compliance with treatment care plans?
So those are all possible measures of healthcare utilization or health system measures. Here's another way of thinking about it. If I would suggest to investigators who haven't been thinking about measuring the impact of interventions in this space to think, if I were to go talk to my healthcare system or hospital administrators and to show them that I had this great intervention that really seemed to make a difference on patient and caregiver health outcomes, what additional data would they want to see to either consider integrating that intervention within clinical practice or to help foster and facilitate partnership with community organizations to help disseminate it that way? What are the administrators in a given healthcare system interested in seeing? That's the way I would think about it, because again, specific cancer patient populations who are undergoing treatment, who are undergoing specific regimens are going to have different kinds of potential healthcare utilization experiences. And so I would ask it more on what is my defined population of interest, and how can I what kind of interventions would actually help move the needle. And it may not always be reduced healthcare utilization. Perhaps intervening with caregivers in a particular context actually helps support them in getting their patient to their regular follow-up visits, helping them adhere better to their medications, helping them to know when they should appropriately seek more medical attention. So that, in that case, that would be more increased utilization, but potentially more optimized utilization.
Great, and Erin, we have a question about timeline for grant submission in terms of the timeline of review and resubmission. So if an application is due in October, when will the application be reviewed?
Sure, because these are special receipt and review, so because there's a special emphasis panel, as Michelle was mentioning earlier, there are 2 designated review panels that are going to convene to review the applications that come into the different dates. So last year, the review panel for the October submission was in February, or it might have even been, I'm sorry, I'm misspeaking. It was in early March, so it was in the winter cycle of grant review. So one should expect that it could take anywhere from 4 to 5 months to undergo review. And the summary statements have been coming out rather quickly, so hopefully that will continue. And so, typically we advise applicants that it takes about a year from submission of a grant application to award. And, so it's going to take probably about 5 to 6 months before review and receipt of summary statement.
Okay, and another question asks, can the intervention and or assessment include components to be provided to cancer patients as well? And I'll go ahead and take this one, Erin. So The application requires that the intervention is delivered at least to the caregiver, but it can also have components that are delivered to the patient or care recipient. And in another question, Erin, you mentioned that caregiving expertise was necessary, but broadly construed. Can you say a little bit more about what you meant by that?
Sure. So, I mean, the truth is that there are so many different disciplines who are working on and interested and have expertise in intervening to support caregivers. So, the special emphasis panel that gets convened for the review of this, reflects that expertise. So we have experts coming in from palliative care, nursing science, psychology, supportive oncology, health services research. So what we really intended with this is that this would be a multidisciplinary endeavor from both the application side and the review side. But we said caregiving science because we actually do think that there's much to be learned from sort of the more behavioral and nursing and palliative care realms to come together to sort of support caregivers as whole people and support their efforts in taking care of their whole patients.
Okay, and then another question is about the review process after the scientific review panel. So to what extent does the percentile versus other considerations impact this program announcement? And I will say that applications are reviewed by study sections and then receive a percentile score and a priority score. And new or early stage investigators, which we mentioned before, may receive special consideration in that. And then, Erin, it looks like one final question. Does the funding opportunity announcement acknowledge that healthcare utilization in a given system and with caregivers often takes place outside of the formal care context? So referrals to community organizations that provide support, and whether that would fall within the purview of this funding opportunity announcement.
It would. I think that it is within the realm, within the purview. I think I would definitely, that can involve some nuance, and so I would definitely check directly with a program officer on that particular topic, because I'm just thinking how that might relate to, on one hand, it could potentially demonstrate potential for good scalability, but you know, having good, reliable measures of healthcare utilization in the community context may be challenging. So I would say reach out to one of us or another program director if you're already working with another program director on that topic. Great.
Erin, that actually leads into one very final question, and to anyone that we didn't get to on the Q&A, we will be sure to follow up, and we will have an FAQ section on the website. But Erin, which program directors are going to manage the R01 and R21 program announcements for this funding opportunity?
So at this time, both Michelle and I, Erin Kent, will be managing the grant applications coming to the announcement, but some applications and awarded grants might be assigned, particularly in the referral process, to program officers outside of HTRP, possibly even outside of our division, the Division of Cancer Control and Population Sciences, depending on a few factors. Number one, the content of the actual application, and then sort of load and bandwidth. So there's a lot of program directors who have an interest and expertise in stewarding cancer caregiving science, and so I would say that it may come first to Michelle and or I, but then it's possible that it could be referred to another program director.
Great. So with that, we will end. Erin and I would like to thank you for joining us. In addition, your feedback is very important to us to design future webinars, so we would appreciate it if you could complete a quick survey that should pop up at the end of your webinar. And we invite you to stay connected with us using our webpage link there, as well as following us on Twitter. And please, we encourage you to contact us with questions about this funding opportunity. Thank you all and have a great day.
Thank you.